We're going to move on to the second topic. The speaker will be Dr. Chang Kyu Lee from Korea University Annam Hospital. The title of his talk will be Molecular Diagnosis of COVID-19 in Clinical Laboratory. Dr. Lee, please.
Hello, everyone. Today, I would like to talk about molecular diagnosis of COVID-19 in clinical laboratory. As many of you may already know well, molecular test is the one most widely used for diagnosing COVID-19. For reliable COVID-19 tests using molecular methods, following three components would be very important. First, quality of specimen. Specimen should be taken from appropriate sites and adequate amount be taken. Second, high yield and pure RNA template is necessary. Third, good performance of RT-PCR is essential. I would like to cover these ones. First, for specimen, nasopharyngeal swab and sputum are most commonly used. This is nasopharynx. It has ciliated pseudostratified columnar epithelium, just like lower respiratory tract. Meanwhile, oropharynx has non-keratinizing stratified squamous epithelium. Coarse food material passed through oropharynx. So, we should take specimen from these respiratory mucosa like this. This is Wikipedia site on COVID-19 testing, showing two pictures. In my opinion, throat swab is not good. When we did shell viral culture for influenza in the past, we had taken MP swab and throat swab from the same patients and compared the results. Hundreds of infected cells from NP swab were noted. However, throat swab showed a few infected cells. There is a big difference. If another swab is available, it would be better to get another NP specimen through the other nostril. As you can see here, flocked swab having brush-like hair is useful in getting adequate amount of virus and infected cells. Universal transport media usually contains a few beads. Sputum is sometimes hard to process. I would like to introduce one simple method. Use 2 mL microcentrifuge tube. Add a bead. After taking about 0.5 ml of sputum, with the aid of simple cotton swab, then add an equal volume of universal transport media and mixed and vortexing. Then, after centrifuge, use the upper layer as a specimen. Second topic is nucleic acid extraction. Manual extraction method is laborious and time-consuming. Above all, there is a chance of cross-contamination, which can give you false positive results. We hate this. We use to automate nucleic acid extraction system. It is simple, convenient, and minimal cross-contamination. One is SLA32, automated extraction system. The other one is Seagen Starlet. It is automated extraction and PCR setup. PCR reagents are automatically dispensed inside the equipment. Laboratory workers handling COVID-19 specimen should wear level D equipment. SLA32 is a small device compared to Starlet. SLA32, it has magnetic silica beads which are coated with silicon dioxide. Negatively charged nucleic acid bind to positively charged silicon dioxide. In the first well, sample and the lysis buffer are mixed together. After that, thorough washing is done in well 2 through 5. Finally, RNA is eluted. It can handle up to 32 samples. Actual running time is 45 minutes. This one is Starlet equipment, which can handle 96 tests for 2 hours and 40 minutes. It has also a small device just for extraction. So topic is RT-PCR. To detect SARS-CoV-2 viral RNA, real-time RT-PCR method is widely used. Most of the commercial products adopt one-step method by which reverse transcription and real-time PCR are performed in a single tube. We have used 2 products made in Korea. One is PowerCheck from Kojan Biotech. It received first emergency use authorization in Korea. The other one is Allflex from Seagen. PowerCheck use recommended sequence from KCDC, E gene, and RDRP gene. E gene is for SARS virus. RDRP gene is specific for SARS-CoV-2. We need two tubes for one specimen. This graph shows E gene positive, RDRP gene positive. It is SARS-CoV-2. If E gene only is detected, it is sarbecovirus. If RDRP gene only detected, it is an inconclusive result. Then repeat test or test with another specimen. Regarding the performance of PowerCheck, limit of detection of E gene is about 28 copies per reaction. RDRP gene is 38 copies per reaction. It shows no cross-reactivity with these all virus and bacteria. Next one is Allflex from Seagen. It can detect 4 targets in one tube using advanced multiplexing technology. E gene, RDRP gene, N gene, and whole process control for internal control. Another good point is whole process control. It is added from the beginning, so we can verify extraction process as well. As you can see, E gene, LDRP gene, N gene, internal control. Regarding performance of RPlex, limit of detection of E, RDRP, and N gene is 100 copies for reaction. There was no cross reaction with all these 61 viruses and bacteria. Before COVID-19 test got started in clinical laboratory, National External Quality Assurance Program was launched for quality assurance. It is hosted by Korean Association of Quality Assurance for Clinical Laboratories and Korean Society for Laboratory Medicine. This is homepage for this site and login site. They sent 7 samples, positive and negative samples. If the result is positive, CT value is also required. PCR equipment name, company name, reagent name is also write down. They gave these results acceptable, or this whole process took just 5 days in our country. I would like to share our experience in clinical lab a little bit. Our hospital is located in Seoul with 150 beds. We do COVID test 4 times per day. Each run takes about 5 hours. We can handle maximum 352 samples per day. First run begins at 7 a.m., second run 1 p.m., third run 6 p.m., fourth run 11 p.m. This is the first case we experienced on this February of 15th. The route of transmission is unknown about this 81-year-old male. There is no history of travel abroad, strongly suggesting community transmission in South Korea. In this case, E gene was positive in MP swab, but LDRP gene was negative in MP swab, just above the cutoff value, 36.26. So we asked clinician to send another specimen, sputum. In this time, with sputum, LDRP gene was positive. CT value was lowered, just below the cutoff value. For 2 months from February to April, 3,700 about tests were performed in our lab. And the positive rate was 0.4%. Nationally, 477,000 of our tests was carried out until April 7th. Positive rate was 2.3%. Thanks so much for your attention.